Attention, the following program discusses matters of health and wellness and is for educational purposes only and does not provide professional medical advice. Please consult your physician for personalized medical advice if you're seeking medical advice, diagnoses, or treatment. The views and opinions expressed on this program are that of the host and/or the views of the persons interviewed and do not necessarily reflect the views and opinions of CHLY 101.7 FM, its staff, sponsors, volunteers, or members.
Welcome to episode 30 of Orange Bench Radio here on CHLY Nanaimo. I'm your host, Derek Poderico, your friendly neighborhood family doctor. We opened the show with Shadow of the Day by Linkin Park from 2007, a track that gently reminds us of the quiet realities of loss, love, and letting go. Sometimes solutions aren't so simple, sometimes goodbye's the only way. It's a song about acceptance, about finding peace in painful moments, a powerful emotional reflection of what advanced care planning is all about. Today's part 2 of Advanced Care Planning, What Matters in the End. And once again, we're joined by Dr. Rachel Carson, Nanaimo nephrologist with a special interest in helping people prepare for the future with compassion and care. We begin with a discussion on medical decision-making and how to guide patients and families through it. We're talking today on Zoom. Dr. Carson, just curious, how do we counsel patients how to make medical decisions?
That's a really good question, and also one I'm super interested in. I think, kind of like I have said before, it's making medical decisions or choices around treatment is really not about like choosing items off a menu where you may not actually even understand the words on the menu. It's instead, it's really about your healthcare provider, your doctor, your nurse practitioner, your nurse, helping interpret for you. And so the questions that I always encourage my patients to ask when they have to make some kind of a decision, the questions that they want to know are, what's likely to happen if I do this? What's likely to happen if I don't do this? And what are the alternatives to this option? And that's those 3 questions are a really good way to get at what the medical decision means for this person. And then once we've sort of got that information, I always want to frame medical decisions about treatments, a yes or no around a treatment, as a trade-off, because everything in life comes with a trade-off. As my sister always says, life is a series of trade-offs. And it's really true. So everything we do, every pill I prescribe has a potential upside. And almost all of them have a potential downside too. And it's not just the price tag that you pay in the drugstore. There are downsides in terms of side effects and adverse events. So
benefits and costs.
Yeah. And so there's material costs, but there's also the cost to the person. And that's really true of medical treatments, including, procedures and surgeries and all that stuff. So when people are making medical decisions, we try and have a shared decision-making model so that we can coach patients to think in that trade-off form. So sure, you might be being offered a treatment that has a potential upside for you, but you always got to ask, what's the potential downside? What am I trading away? And when it comes to closer to the end of life, sometimes treatments that are offered theoretically to extend someone's life actually end up stealing away the time they have to do the things that matter. Yeah. And so that's a really important thing. And actually, unfortunately, dialysis is one of those things. Like I said, dialysis is like the worst part-time job ever. It's like 12 to 15 hours a week. You got to go forever. You can't miss a day. It kind of uses up your time. Right. And so if someone tells me, the most important thing to me is to have as many hours, minutes, days, months, weeks at home, with my dog, then I'm going to say, dialysis might not be for you, because past a certain age, dialysis may not actually help you live any longer, but it sure will use up your time coming back and forth to the hospital. Right. So it's important to think about trade-offs, and that's true for anything else, even something like a surgery. You have to think about, okay, it might give me this benefit, but it's also going to take, and you have to decide whether those trade-offs are worth it for you.
The conversation then shifted toward the idea that advanced care planning is not a one-time document, but a living, dynamic conversation.
Yeah, well, and another thing that's also really important to note is that this is a dynamic living conversation. So this is, there are a few kind of things that I often find myself saying. And one is that it's not like a menu. It's not a kind of sit down and future date that you will or won't put up with. It's much more a living conversation that might change over time as your health changes over time. So the same way a pair of pants that fit you 10 years ago doesn't fit you now, medical decisions or priorities that you might have had 10 years ago may be pretty different than they are today. So it really is a longitudinal effort. It's not like you have one advanced care planning conversation and you sort of wash your hands of it and that's all done.
File
Tick.
away.
I don't have to do it again.
Yeah.
It's very much, it's dynamic. It needs to kind of be revisited. Like, okay, this happened.
Yeah.
Now that kind of changes things. What are your priorities now? So it really is a dynamic thing. And that's where, unfortunately, having a physician, a primary care physician, a family doctor, a nurse practitioner, or a specialist that knows you really well, we really need that kind of guidance in terms of, again, I know as the specialist, I know this giant list of textbook answers to how to treat your conditions, but I also need to know where you are now in your life and what your priorities are now. So there's also there's always more paperwork because it's healthcare.
Yeah.
There's also a form called a MOST, which is a medical order for scope of treatment, and that's actually like it's a doctor or nurse practitioner order, so it's not something that the patient fills out.
Right.
But it's kind of it sort of describes six kind of scopes of care, six philosophies. Yeah, and it kind of just helps us as the healthcare system kind of know, again, what the patient is prioritizing and kind of what they're willing to put up with in terms of interventions we might be offering. And it should never replace a conversation. So if a person can have a conversation with us or they have a substitute decision maker,
right,
this form, this order, which some people used to call DNR orders or full code orders. It's a guide. It kind of helps us frame in general what's this person's philosophy around putting up with medical interventions, but it's kind of like the cherry on top of that ice cream sundae I was talking about. So if you just have a form that says, do CPR, don't do CPR in an empty bowl, that's not a very good ice cream sundae, right? Like the form, this MOST form is really, it's just an ice cream. It's just a cherry on top of a sundae, and the rich ice cream and the chocolate and the sprinkles is those sort of important conversations where we talk about those questions I mentioned earlier.
Yeah.
So I think it's important to have a MOST because if you're so unwell and it's in the emergency department, it's good to know what you would and would not be willing to put up with or go through for the possibility of more time. But it doesn't, it finishes off the sundae. It doesn't substitute for the sundae.
Right. Totally.
It's kind of how I think about it.
So well said. And for the listeners, I mean, it's not dark or morbid, just to understand what the M's and the C's mean. Can you go through for listeners what they all mean?
Yeah.
And then we'll put it up on the website as well.
Sure. Yeah. And again, I think it's actually not really, it's not even really that important because we're going to change, we often change the short codes for things, but what doesn't change is kind of what actually doesn't change is really the philosophy behind it. So in general terms, sort of people who are willing to put up with, for instance, really invasive treatment or procedures in an ICU. At the moment in Island Health, there's sort of a group of 3 scopes that would fit with that. And that's sort of saying, I want my life preserved kind of almost at any cost. I'm willing to put up with sort of the worst stuff you got. And I'm willing to try and go through that for the potential of surviving. Yeah. And that would be kind of a typical, that's sort of the default. It is actually the default. So we always default to that. But there are a lot of situations in particular as people age or as they have have advancing chronic illness where it actually doesn't make sense to do those things because all it's doing is making the last moments of life chaotic and painful and instead of peaceful.
We'll return to our conversation with Dr. Carson in just a moment, but as you know, Orange Bench Radio is also about the music. I asked Dr. C if there was a song that she'd like to hear, and she chose a poignant and a poetic Canadian classic, Calling All Angels by Jane Siberry from 1991. Here is Jane Siberry with Calling All Angels on Orange Bench Radio.
placed upon the steps, a baby cries, and high above you can hear the church bells start to ring. And the heaviness of it settles in, and somewhere you can hear a mother sing. Then it's one foot, then the other, as you step out on the road. You step out on that road. How much weight? How much? Then it's how long and how far and how many times. Oh, before it's too late. Carnal angels, walk me through this one. Don't leave me alone. Carnal angels, we're trying, we're hoping, but we're not sure how. Oh, and every day you gaze upon the sunset with such love and intensity. Wise, almost as if, oh, if you could only crack the code, you'd finally understand what this all means. But if you could, do you think you would trade it all the pain, suffering? But then you would have missed the beauty of the lay upon this earth and the sweetness of the leaving. Carnal angels, walk me through this and don't leave me alone. Carnal angels, we're trying, we're hoping, but we're not sure how. Carnal angels, walk me through this one. Don't leave me alone. Carnal angels, we're trying, we're hoping, we're loving and we're hurting, we're crying, we're calling, 'cause we're not sure how this Carnal
Wow, what a haunting and hopeful song. Lyrics like, "But if you could, do you think you would trade it all the pain and suffering? Ah, but then you'd miss the beauty of the light upon this earth, and the sweetness of the leaving." It speaks to both the ache and the grace of letting go. To close out today's show, we spoke about what a Do Not Resuscitate order, or DNR, really means, and how to approach that decision with clarity, care, and compassion.
What we used to call a Do Not Resuscitate order or a DNR order someone might choose that for themselves and say, I don't actually want to ever go to an ICU. I had to go to ICU, 3 years ago, and it was the worst experience of my life. I never want to do that again. I'd rather die.
Yeah,
and so that that's how we know that person's preferences in terms of what they're willing to sort of put up with. So so I think those are really kind of important things to have, but again, it doesn't replace the conversations, and we shouldn't really have a most unless we've had a conversation. It's like having an empty bowl with just a solo sad cherry in it instead of ice cream.
You need the rich ice cream and the chocolate and everything in between. Yeah,
exactly.
So
and
well said.
The last thing I often say is that what we used to call a DNR order is not a DNPA order. It's not a do not pay attention order. So it's really important for people to know that actually you almost have to pay more attention to the people who've said, I don't want to do ICU or resuscitation, because you kind of have we've said, okay, we're not going to use those tools. So we better be super attentive and see what tools we can use in some ways. So it really just applies very specifically to a cardiac arrest situation. And on TV, if you watch ER, well, this audience is way past the old school ER show, but
there's
Grey's
now
Anatomy
The Pit
or any of the medical shows on TV. It looks like almost everybody who gets CPR survives. So somebody did a paper on this a number of years ago, and it's something like 7 out of 10 people survive resuscitation on TV. But real life is a lot worse than TV. Unfortunately, we're not nearly as good as those TV doctors. We're not as good looking, and we're not as skilled, because in real life, it's closer to sort of maybe 5 to 10% of people. So like 9 people getting CPR die. Maybe in a CCU where it's more a rhythm problem, maybe a few more than that, but the odds are a lot lower. And for instance, someone who has, say, metastatic cancer or like an advanced organ failure, those odds are way lower, to the point where they're 1 in 1,000, 1 in 2,000. So it's really a different ballgame in the real world compared to TV.
You bet. No, I'm glad you brought that up, because not advertised on TV, the reality is much different. And I think, putting it in that context and having those conversations that you can ask and tell and question these things. Yeah. Cool. Anything else that you want to let us know about, Dr. Carson?
I don't think so. I mean, I think, again, just circling back to if you don't have a family doctor, I think it maybe is more important to sort of get that My Voice booklet and kind of look at it. And then if you do have interactions with the healthcare system, sort of being proactive about thinking about what your philosophy of care is, like what matters most to you, and making sure you communicate that. And one of the good things, there's been a lot of controversy over the computer system in the island health hospitals, but one of the good things about it is that we talk about making sure that patient priorities are expressed, heard, and respected. Nice. And so if you express what matters to you, we need a way for it to be heard, not only by the person in the room with you, but by all the people who might care for you in any facility on the island. And we actually have, so that they can respect what matters to you. So we actually have a pretty good way to do that. And we're seeing increasing amounts of information being put into the system about what matters most to people, so that whether you show up at midnight on a Saturday night in the emergency department or at 2 p.m. in an outpatient clinic, everyone who cares for you can see within 2 clicks, what you've said before. They can in quotes hear it.
Amazing.
Even though they weren't in the room with you.
Yeah, and that's amazing medicine that you're doing. And I'm just going to say kudos to you, because I think a few of these innovations are related to your passion and advocacy for this topic. So thank you so much for your. Well,
as you can tell, work. It's definitely my swan song, my life's, it's really my life's work, to be super honest with you. So, yeah.
No. You're so inspiring. You got me inspired even more. Get back out there and have more conversations that matter.
Exactly. They really do. They feel like the most meaningful part of my work a lot of days, so cool. For sure. So
I appreciate your time, your wisdom and expertise. Thank you for being on Orange Bench Radio today.
It's my privilege.
In part 1 of the series, we opened with the phrase memento mori, remember you must die. That might sound grim at first, but it's not meant to be morbid. It's a Stoic reminder of our mortality, not to frighten us, but to help us live more fully. Advanced care planning can feel like a heavy subject, talking about the end of life, but time and again, both in Dr. Carson's and my practices, these conversations actually lighten the load. They bring understanding, they spark connection, and they often lead to a deeper appreciation of life for patients and families alike. When we take time to reflect on what matters most while we're living, it helps guide our decisions when the time comes. We've posted some of our helpful resources on our Orange Bench Radio, Blue Sky, and X sites, including No Cardiopulmonary Resuscitation, or CPR, Most Medical Orders for Scope of Treatment, and My Voice, Planning Ahead for Your Care. And if you don't have a family doctor or a nurse practitioner and want some guidance on how to navigate these important decisions in community, feel free to reach out to me, Dr. P, at orangebench@chly.ca. Also remember to sign up for the Health Connect registry to get on the list for a family doctor or NP. Memento mori, not as a shadow, but as a light to help us with intention, courage, and clarity. Thank you for tuning in to Orange Bench Radio. Special thanks to our guest, Rachel Carson, Nanaimo nephrologist, for her time and wisdom today. You can catch this and previous episodes at orangebenchradio.ca. For questions, comments, or ideas, reach out to us at orangebench@chly.ca or follow us on Blue Sky or X at Orange Bench Radio. Remember, it's all about hope and healing. Join us next Saturday at 9 a.m. as we kick off your weekend with more music and conversations that matter. A big thank you to Jesse Woodward for producing, Arby Frew for technical support. I'm Derek Poderico, your friendly neighborhood family doctor, and this has been Orange Bench Radio on CHLY Nanaimo.
Find the places we got her, digging in the dirt to find the places